Hello everyone, so today we are here with a really interesting case study. Wanna see what is the case, so let's get into it. So we have a patient. He is a 65-year-old male, with a history of smoking, hypertension and hyperlipidemia, who states that the vision in his right eye became blurred and then completely black, and then returned, in about 1 or 2 minutes. This happened while he was having dinner 1 week ago. He had a second similar episode a day later, in the same eye, this time while reading the newspaper. Since these 2 episodes, his vision seems normal. He also has noted a nagging right temporal headache, that is severe at times. He has been more fatigued recently. He has had a 10-pound unintentional weight loss, in the last 6 months. He was started on a new medication, for cholesterol 2 months ago, and experienced sore key muscles. Workup was done by his primary care doctor, for the muscle ache. As part of this workup, an erythrocyte sedimentation rate (TSR) was checked, and found to be elevated at 116. Past ocular history: he had corneal abrasion 3 years ago, in the right eye due to trauma. No prior eye surgeries, amblyopia or strabismus. No ocular medications. His hypertension and hyperlipidemia is under good control. He has got his knee surgery done a few years ago. Past family ocular history is negative for macular degeneration, glaucoma or any blindness. Social history: he is smoker, 1 pack per day from 40 years. No history of allergy. Let's talk about his ocular findings. So his VA of right eye is 20/20 and the left eye is 20/25. His intraocular pressure is 14 and 13 mm of Hg respectively. Pupils are normal, reactive and round, no APD. Extraocular movements is full, and no nystagmus. So this is his slit lamp examination. Lid and lashes are normal, but anterior chamber is deep of both eyes. Iris and anterior vitreous is also normal, but lens has nuclear sclerotic cataract. Fundus examination shows clear view. Cup disc ratio is 0.2, with an hemorrhage superiorly, and some cotton wool spots around the nerve. Flat macula with normal foveal light reflex, normal vessels and peripheral retina. Left eye fundus is also normal. So it is real interesting case study. Pause the video and think about the answer. So, let's have a look. An answer. He is suffering from giant cell arteritis, or temporal arteritis. It is inflammatory vasculitis that affects medium and large-sized arteries. The most typically implicated arteries are the vertebral arteries, superficial temporal arteries, posterior ciliary arteries, and ophthalmic arteries. It is an aging illness that can cause a variety of systemic, neurologic, and ophthalmologic consequences. The most prevalent cause of morbidity in GCA is vision loss. To avoid blindness, early detection and treatment are required. Patients frequently appear with an abrupt, painless loss of vision. The patient in this case was having occasional blindness known as amarosis fugax. Patients may also have anorexia and weight loss, as well as an antecedent or concurrent headache, jaw claudication, pain over the superficial temporal arteries, proximal muscle and joint aches. Patients may arrive with just minor symptoms. As the condition advances, ocular atrophy and optic nerve cupping may ensue. Elevated ESR, CRP and platelets are supportive of the diagnosis. As soon as GCA is diagnosed, systemic corticosteroids should be administered to reduce arterial wall inflammation and stop permanent blindness brought on by ocular artery obstruction. 4 corticosteroids can be given if the patient does really have acute visual loss. Once the vision has been down for several hours in an eye, it is unlikely that vision recovery will occur. However, steroid treatment should be given to minimize the loss of vision in the affected eye and to prevent involvement in the other eye. So what did you learn from this case study? Solve this question and do let me know in comments box that did you get the right answer or not. So the answer is: start steroid medications immediately, either 4 or oral, after confirming an elevated DSR and CRP to prevent vision loss in the contralateral eye. Thank you. It's time to say